All right, I think we're going to go ahead and get started. Welcome to the continuation of the Diversity Nursing Workforce Conference. Hopefully you were able to attend a breakout session and have some good conversation. I know we did in ours related to cultural competency and diversity and inclusion best practices. And I think a lot of the takeaways from today has really been that we're never really done. We're never really done with cultural competency, building a diverse workforce, what that means, how it's defined. We're never really done with it. It's really more of a journey about the process and about remaining humble and asking those curious questions. So hopefully you were able to take away something from the breakout sessions and attend the career fair earlier. We're really excited about our keynote tonight, and hopefully we'll have an engaging dialogue. We'll be able to talk more about diversity and inclusion over at UCSF, just a little bit west of here. And so I look forward to having that discussion with Dr. Martin Holland. Dr. Dan Willis, our Associate Dean of Academic Affairs, will be introducing our keynote. Thanks.
Thank you, Mel, and I look forward to all of you joining me in a hand of applause for our speaker, Dr. Julie Martin Holland. I had the privilege of having dinner with her last night, and I wanted to say that she is also a foodie, and she thinks that Madison is a foodie town, so I think that's pretty good. Dr. Holland Martin is the Associate Dean for Academic Programs and Diversity at University of California in San Francisco. Her research interests are in healthcare disparities and patient-focused healthcare decision-making. She is very passionate and loves to talk about nursing, and so we're going to hear from her this evening about her passion for nursing and cultural competence. And she's also very involved in the recruitment, the retention, and the graduation and the forward movement of diverse nursing students, and we're going to hear about that too. So again, thank you, Dr. Holland Martin, for being here.
Thank you. So I wanted to just take some time at the beginning to first say thank you to Dean Scott and to Dr. Mel Freitag, in Dr. Scott's absence, for inviting me to speak today. I've been the recipient of a very gracious and warm hospitality since my arrival here in Madison. Dean Scott, Mel, and Dr. Willis and I had a chance to go to dinner last night. Had a great time. I gotta tell you, I am a foodie, and Mel found out all about my wine taste as well. So we had a wonderful time. I appreciate the opportunity to meet with the admissions advisors this morning, and the undergraduate counselors as well. And I met the lead faculty member for the DNP program here. We're just getting ready to open our DNP program in about 5.5 weeks at UCSF. So it was fascinating to meet with them this morning. And I'd like to also recognize Tara, who served as my student ambassador. There she is. Thank you. And congratulate Brianna, who's here. I know she's getting recognized and getting an award for her work. She's in the back. And I truly appreciated the lively conversation that the students and I had during lunch today. I've been asked to talk about my own personal story and journey in nursing, and I'll try and weave that through 3 areas that I'd like to have some discussion with you regarding diversity in the healthcare workforce this evening. And I'm hoping to provide you with a glimpse of what's becoming a welcome tidal wave, I think, in our profession to increase diversity amongst our ranks. I'm going to introduce this by concentrating on 3 buckets. I'm going to just briefly touch on why diversity is important, because I know a lot of that work is happening here, and so you have a sense of it as well. I'm going to touch on what we're doing about it as a profession, and then in particular for the students, I'm going to talk a little bit about how you can help with the process. So first, because I was asked to talk a little bit about my journey into nursing, I will say that, I've been a nurse for a few years. We're clearly into double digits. And I went to nursing school in the 1970s, which was a very interesting time in California. I went to a state program in Northern California. It was in a rural, mostly farming area, farming and ranching. And there were 35 students in my cohort. There were, out of that 35, 2 that were African American, 1 that was Native American, 1 that was Hispanic, and 1 that was Asian. And the 5 of us got to know each other very well, and we hung together very closely for the entire 3.5 years. We're in Butte County in Northern California, and largely the population there were Caucasians or whites and Hispanics. Hispanics because it was a farming community, and so largely that's what the Hispanic families were involved in. Worked at the county hospital initially, and the students that were at the lunch today learned that one of the reasons why I decided to go to that nursing school was because of the variety of experiences that you could have as a nursing student. So we started out in that rural area that I talked about, and many of us, as I mentioned at lunch, prayed every night that the mountain pass would close so we didn't have to be at clinicals at 6 o'clock in the morning in a place called Paradise, California, that didn't feel like paradise at the time. And from there, and we also worked at the county hospital there, and that's where we saw a lot of the immigrant families. From there, we moved to the Fairfield area where there was Travis Air Force Base. And at Travis, we spent 2 days a week there, so we learned a lot about military nursing. That was a very different environment because military nursing in the 70s was actually very diverse, and nurses had a very broad-based scope of practice there. It was really the first time that I began to appreciate that nurses had such autonomy in their practice, and it was through military nursing. At the same time, while we were living in the area of Fairfield, we experienced our psych mental health rotations at Napa State Hospital, which was a very famous, at that time, mental health hospital that was self-supporting. They had their own farms, they had their own, they grew their food, raised cattle, so patients were kept busy in more vocational and care type settings, and so it was a very cutting-edge mental health hospital at the time. And then for our last semester, we went to Oakland, which is where I live now, and we worked in a traditional county facility. So many of you, if you've been looking at any of the public health stats over the last few years, are aware of Alameda County Hospital, otherwise known as Highland Hospital in Oakland. It's a teaching facility. It's a huge county facility. And so we spent our senior year in Oakland at that large county facility. So there was clearly an advantage in terms of looking at the variety of experiences that we had as nursing students. However, the 5 of us that were the minority students in the program, with the exception of the Asian student, we all experienced some type of controversy with regard to caring for patients, particularly older white patients at the time. There would be plenty of times in which we would walk in the room with our nurse or with our preceptor to say that we were the nursing student that day, and we would be asked to leave the room. And so one of the things that was very helpful to me as I was going through that process, there was one professor in particular that recognized that this was happening to us, and she would always sort of bring us aside and say, you know what, it has nothing to do with you, it has everything to do with them. You, on the other hand, need to move on to a patient where you can get the experience that you need. And she would always find somebody else for us to work with. So just as a mental note, because I know that this still happens today, believe it or not, I hear about it in my role at UCSF, that occasionally there will be a patient that, one of our students will go into the room with another provider, and the patient will say, I don't want that person caring for me. So just remember, if you're ever in a preceptor role or if you're in a faculty role in a clinical situation in which this happens, while the patient has their rights, it's the student that needs the support at that time. So I'm going to move on and get to my first slide, where we're going to talk a little bit about Dane County, Wisconsin. Now, I'm assuming that many of you have seen some of these statistics before. This is the population of Dane County as of 2016, and I've noted here the website where I've pulled these statistics. And basically what I want you to know, if you are not aware of it already, is that essentially Dane County has about 20% of its population that is not white or Caucasian. I'm going to go, let's see if I can make sure that I can do this right. I might have to ask, nope, that's not it. Ask for a little bit of help from the tech person. Comes back, thank you. Isn't that perfect? Yep, to go to the web page. Thank you. Disappeared. There we go, it's back. So many of you may be aware of these statistics, but what I'd like to point out to you is when we go to the major disease categories and we look at who has the experience of disease in Dane County, as you look at breast cancer, for example, there's actually a fairly comparable number of 127.9%, looking at race and ethnicity in breast cancer incidence, so 127.9 for whites and 116.4 for Native Americans. If you look at cervical cancer, all of a sudden the numbers change dramatically. So if you look at the burden of disease in cervical cancer, you're looking at 14.6% of the diagnosed individuals are Native Americans, 12.2% are Asians or Pacific Islanders, African Americans are 12.4%, Hispanics are 9.9% of the burden. Get into lung and bronchitis, bronchus cancer and lung disease. Again, numbers are high for Native Americans, for Asians, and blacks, much lower for whites. As you look at the more common chronic diseases such as diabetes, you'll see that deaths from diabetes are essentially run the same. Age-adjusted death rate due to diabetes. Native Americans, 60.8%, blacks are 38.4%, and Hispanics are 26.1% death burden from that disease. So as you look at these disparities, you think about where our priorities are as a nursing profession or a healthcare profession. You recognize that just in this county alone, the burden of disease here rests with the 20% that are not the majority of the population in Dane County. And the question that you have to ask yourself is, as you look at the 20% carrying almost 90% of the disease, where does that line up with our values and our priorities as a healthcare system and as the health professions? How is it that we can look at those outcomes and believe that we're making a difference in people's lives when this type of disparity is still in place? A great pause when you think about where Dane County is spending its resources in terms of healthcare dollars. Because as you look at these conditions, what you learn from them very quickly is these are the conditions in which people are spending a lot of their time in the highest cost portions of our healthcare system, getting care in hospitals, because their disease is becoming overwhelming pretty quickly. It's a little, as you think about these results, one of the things that we talk about with patients sometimes in terms of setting up their motivations and looking at their outcomes to get a sense of where their intentions or their motivations are, it does ask us where our values are as a society. It asks us how these outcomes align with our values and what will move us towards a different set of outcomes. Clearly, we need to change our approach. And that also means we need to change our thinking. We're well beyond blame. It's not that any of us at this point in time are working in systems that we help create, right? It doesn't matter if you are 90 or 100 years old and you're sitting in this audience or you're going to listen to the recording later. Many of the institutions that most of us are working in now and many of the systems that have been put into place that may have caused these outcomes are systems and institutions that we're working in and working for, but we did not create them. They've been around for a long period of time. We've had issues with housing, education, and poverty in this country for longer than 80 or 90 years. So if you think about the generations of people that have been affected by those things, we're well beyond blame, but it is time for us to think differently about how we are going to approach these problems or concerns. So what do we do now? Why is diversity important? Well, Albert Einstein told us almost 100 years ago, quite frankly, that we can't solve our problems with the same thinking that we've used when we create. So we're in this place, and in terms of trying to move forward, we have to think more proactively about what we should do. Nursing as a profession value very much what patients and families and communities tell us about what their needs are. That's where that and the scientific foundation of our practice are the two things that we meld together to care for each and every individual that we care for. The best nurses are those that listen to the patient, tell them how to care for them. We add that to our expert knowledge and our scientific basis, and that's why nurses are identified as the most trusted professions in the healthcare system overall. Patients recognize that we listen to them and we pay attention to them, and we augment our care in recognition of who they are and where they come from and where their values are. So as we think about approaching these major problems around health inequities, we need to use the same approach that we've used as a profession in the care of our patients and communities. As a profession, I'm proud to say that nursing is actively working towards increasing our diversity within our ranks. And when I say our diversity, I'm not talking about just bringing people into 2-year RN programs and sort of leaving them there. There's work both in my state and nationally to create articulation agreements for people to move from associate degree programs into baccalaureate programs and then continue to build a career ladder in which they have opportunities to increase their education. We're starting to bring, as you think about it, over those of you that have been in education for the last 20 years, 25, 30 years ago, you would not hear of BS to PhD or BS to DNP programs. This is something that nursing's doing, recognizing that we need to move people through to the higher states of our profession in terms of their education preparation so that our science is much more appropriate for the communities that we serve. So that's a shout out to students to think about. I know many of you, particularly students of color, will come into the profession thinking, I want to go back and serve and give back to my communities. And we absolutely want and need for you to do that, but we also want and need for you to go further in your education so that we can make sure that the science that we're producing that will undergird the practice of nursing is appropriate for those communities as well. We're shining a light on our health inequities, and we're doing that through our research, we're doing that through our practice journals. It's really been nursing and medicine that have taken a lead on recognizing that it's not okay to just call people frequent flyers and to deal with them when they show up again in the emergency room, but to really start to question and to look back to see what has gotten us to this point. What are patients and families living with? What's not happening in the rest of society to support them so that they can be healthier individuals? And it's really been nursing research and Medicine that have taken a lead on making sure that those journals are there, that are giving testimony both nationally and in individual state houses to talk about the societal needs, the societal changes that need to take place for us to be better at reducing health inequities. So our researchers are starting to measure outcomes by race, by ethnicity, by sexual identity, by geographical areas, rural versus urban areas, for example, and other factors. We're recognizing that there are differences on the basis of where you live. In California, there's been a major movement with one of our large philanthropies, the California Endowment, who has recognized through their own research that it's the zip code that matters, right? If you are in certain zip codes, we can tell you at birth what your life expectancy is, what the propensity is for you to be, if you're male, if you're going to be incarcerated during your lifetime. It's amazing what we have learned from starting to follow those statistics over time. Those large longitudinal studies have given us a lot of information and predictability for both health outcomes as well as life's circumstances for our citizens. And we're trying to make an impact on those areas that we have learned truly impact not only an individual's health, but their well-being. Some of the work in California by the Endowment was very surprising. So about 10 years ago, I can tell you that the schools of nursing who had depended on endowment money to help fund increasing our diversity in our nursing schools, because I was one of them, they decided to change their funding priorities such that they would give the money to communities. And, the first reaction was, you gotta be kidding, I got students, I need scholarships, the typical educator response, I would say, because I've had that money for a while. But when I thought about it, it made sense. They wanted communities to be able to take some responsibility for their own outcomes. And so we had faculty and students that got involved with some of our communities in working with the endowment to identify what the priorities were for our communities. What was amazing is across our state, so 58 counties, and there were 2 or 3 projects in almost every one of those counties, the number one factor that communities identified was access to quality education. We asked, what's the biggest impact on health? We thought it would be poverty. We thought it would be, the lack of grocery stores in certain communities, the inability to get appropriate food. We had the list that we had identified. And what they said to us is, it's quality education that we're missing out on. And when you think about that, it makes sense to us. What we've learned over the last 10 years or so is it goes back to poverty, but poverty with a big P, not the little p that we used to use it with, right? We've learned that if children are hungry, they don't do well in school. They don't do well at school, they can't advance. They can't pull themselves out of poverty. So it creates a cycle there. So we're starting to focus again on food security, but we're also focusing on, so how can we make sure that more of our communities have appropriate educational opportunities as well? So that's one of the areas that the endowment is starting to put a lot of their funding behind, is increasing the capacity and the quality of education in K through 12. Nursing, again, is also revising the principles that guide our work. So those of you that have been in nursing for a period of time recognize that there are a couple of major documents that guide our work as professionals that have changed over the last 5 to 7 years. And those are our Code for Ethics and our Social Policy Statement. Both have been updated to recognize sort of the different values that we're putting in place and guiding both in terms of the language that we're using and looking at inclusivity as being a very big part of what we want to represent as the nursing profession. And we'll talk about inclusivity a little bit more in a second. Okay, so let me get back here. What are we doing at the micro level? So some of that work is happening here. You're seeing people begin to recognize that, as humans, we have unconscious biases. I've been doing several holistic review workshops around the country, and I had the most interesting experience recently in North Carolina, in which we were encouraging people to think about where their biases are, particularly when they're reviewing applications. And one individual said, one of the things as I start to think about it is when I see an application from a student who comes from a large family, I tend to do whatever I can to make sure that that student gets into our program. Well, she came from a family of 9 kids, so she knew what it was like to be the middle child in a family that size. So when she sees others that are like her, that's exactly what she advocates for in the admissions process. So one of the things we've started to talk about, and as a part of our admissions process, is we've gone through some of the work that you're doing here in terms of identifying the attributes that you want to see in your applicants to be successful in your programs. And we're starting to fine-tune that more and more so we really can get some inter-rater reliability across all of our applicant reviewers as we're starting to put together a cohort for each of our programs. But I think what's been important is for everyone to realize it's not just certain people that have these biases. All of us have biases. And we need to start thinking about that and put those out there so that in our review committee meetings, half of the discussion is about, I've noticed that this is an attribute that you really key in on as somebody that has to be admitted to our program. And people will sort of stop for a second and say, yeah, I think that might be a little bit of a bias for me. Or I've had a student that's had this type of an experience before, and so I know that those students don't do well. And it's like, well, was that one student? Or is that really something that we need to look at and supporting in our program? Because there are many students that are coming with that difficulty. And we stop and we have that conversation. So it's recognizing and having the freedom and the comfort amongst all of our committee participants to say, I know what my biases are, and I'm going to check them here. I want you all to, when you're seeing them, when you're hearing them, I want you to say something. So as we're starting to put a cohort together, we can be very mindful about the work that we're doing. Starting to build some programs to find supports for our various populations on campus that feel that this is a really new experience for them. So we're talking about teaching people to be an ally. Now in nursing, I think about this as advocacy, because when you think about the role of the nurse in advocating for somebody who may be very different than they are, but who can put their own values and cultural preferences aside to adopt someone else's priorities and to advocate on their behalf. That's work that nursing does on a regular basis. When I look in the literature about what's happening about building allies or allyship, it's really the same thing. It's if you're at the table and you know somebody else is not, and their viewpoint is not being represented well, you can speak for that person. Or if you're in a room and you hear someone say something that is not appropriate, and you watch the other person who may be different sort of shy away from it, as an ally, you can be the person who says something. This makes me feel really uncomfortable. We've been trying to do this with our nursing students because I'm sure it's not just in California, but it may be. There are times that you end up in a community hospital or you end up in a clinical setting, and some healthcare provider that's pretty frustrated about having to deal with a patient or his or her family may say something that they probably shouldn't say about a patient or family. So what we've been teaching our students to do is to say, that really makes me feel uncomfortable. I'm really sorry. I understand you might be frustrated that this is the 3rd time this week that patient's come into the emergency room. But can you imagine what that person's life is like, that they're spending this time in the emergency room? There's got to be something that's going on. And it really changes the direction of the conversation. You can be very compassionate in how you bring it up, but don't just let it go. When someone says something that's hurtful or is not quite right and you can tell it's making someone else uncomfortable, don't allow yourself to move into just a quiet space that almost gives you permission to let it happen. Say something. And that's what we've been trying to encourage people to do through this allyship process. I've been involved with work with several of our nursing organizations. I'm starting to do some work with the American Association of Critical Care Nurses now around changing our position statements for our national organizations and societies in the profession. So position statements, most people think of, a lot of words on a white piece of paper sits up on a shelf. But I have to say that many of these organizations now are starting to move the work forward by expecting that their chapters and their local constituencies take up the work of making true change. So as we've started the work with AACN, then they've been looking to their individual chapters, all of their national awards, all of their recognitions. They're starting to bring diversity and inclusion language as a part of that work. So the really smart organizations are starting to say, okay, we'll have a diversity statement, but we want to make sure that as our policies and our operating procedures go forth, we actually put our money where our mouth is, that we're actually doing the work, that we're not just encouraging everybody else to do. So they're changing everything about their operating procedures to make sure that you can see diversity and inclusion as a value and not have to read it in their mission statement. And then the last piece, I have to say I'm very proud that many of our researchers have been doing work around cultural humility, and we've been working on our curriculum, particularly in our master's program. We're still working in our pre-licensure program to ensure that we are teaching advocacy in its true form through cultural humility. It's not to say that there's anything wrong with your culture. The issue is it's about service. And if you're serving the person that's in front of you, it's about their culture being the one through which decisions are being made. So you have to, again, learn from the patient to adopt a framework of thinking and decision making that respects both their priorities and their culture. And in order to do that, you have to listen to the patient. So again, it gets back to that value that we have as nursing professionals, that if we're listening for the patient and his or her family to help us in learning how to care for that individual. Of course, we bring our expertise and our science as nurses, but we're looking to the patient for the right way to approach it for them, that customization that they're accustomed to for us. And then we're building inclusive learning communities and advancing inclusive excellence. What I mean when I say that is to recognize, and we try and start this at our orientation process. In my work, we're encouraging other schools to take this on as well. There are times when things get said in a classroom or in a learning environment that are the expression of a student or a faculty member's life experience with whatever it is. So, for example, a student may say, well, I understand that, if Asians want water, they always want warm water. It's like, well, really? Is that? Now, that might be their experience. I'm sure if there are certain nationalities of Asian students in the classroom, they're feeling totally insulted by that statement. And so the question is, and what we've started to do is to say, well, that might be your experience with some of the individuals that you've been in contact with during your life who are also Asian, but that's not necessarily true for everyone. So the question is, when you're going to bring a patient who appears to be Asian to you water, you ask, would you like ice? Would you like it room temperature? Or do you want warm water? Again, you're seeking information from the patient to inform you of how to best care for them. But it's rising that conversation. It's to get students to recognize, and all of us to recognize, when people say those kinds of things, 9 times out of 10, it comes from their N of 1 experience with whatever that situation is. I've had one contact with one person or 10 people who are like that one person, and so now I generalize that to an entire population of individuals. It's not appropriate, and what they need from you in a learning community is to have that questioned, to just say, my experience is a little bit different. Have you ever thought about asking that person instead of making that assumption? And just to ask questions in a way that somebody can hear you and think about their assumptions and respond in a different way. That's what we're trying to get across. Health systems are also recognizing through their Gallup scores and their Press-Ganey reports that patients recognize when there's diversity on their staff, and they value it. They value it whenever there's somebody who is sitting across from them that they can say, that person looks a little bit like me. That might not be their caregiver that day, but if they see enough of them in the hallway, or they know that that's a value in your staff because they can see it, then the Press-Ganey scores and the Gallup scores go up higher. So let's see if I've gotten myself off of my notes here, because I've been talking a lot extra. One of the things that, as we talk about diversity and how much work we've been doing in nursing to ensure that we've got more diversity in our ranks, is to recognize it's not just about getting people in the door. It's making sure that there is a welcoming environment for them to participate fully while they're there. Part of building that learning environment is to ensure that people feel comfortable sharing their perspectives at the table. Now, sometimes that means when I'm sitting with a group of African American students, I'll get some feedback. Well, I'm not here to represent all Black people. No, you're not. That's not what I'm looking for. What I'm looking for is, because of your experience with African Americans, whether you have a lot or a little, you're going to have a different perspective about living life in the USA than other people that are sitting in that classroom, and that's what I expect you to share. I'm not expecting you to stand up and say, okay, I'm the new Malcolm X. I can tell you what the next protest is going to be. No, but I am expecting you to say, you know what? If you approach people who look like me with this kind of language, let me tell you how they're going to respond. 9 out of 10 of them. Or here's something that I can teach you about approach for people who are of African descent, because this kind of a language won't work. Well, there may be some generalities there. Of course, you're talking about your experience as well. I mean, there are lots of people who look like me that I can't explain to anybody, so I'm just going to be clear about it. I also can't speak for all African Americans, right? But it brings a new perspective into the discussion, and that's how we all learn. The key is, particularly in schools of nursing, we want to be able to learn from you, us as faculty, and your classmates. We're all hoping that everybody in the community is learning from one another. So don't get quiet and sit back and feel insulted. And if there's somebody that says something that makes you feel that way, then bring that up and make a comment about it, because that's the only way the person learns that they shouldn't say whatever it is that they've said. So I love this quote by Melanie Hopson, who says, invite people into your life who don't look like or act like you. You might find that they challenge your assumptions and they make you grow. And that is so true. So what can you do to help? I think in particular for the nursing students, be an advocate. I have the 7 B's here. Be an advocate. Learn how to accept someone else's priorities, culture, sensitivities, framework for which they make decisions in their lives, and advocate for them. As nurses, you will automatically find yourself at tables that patients and their families will never find themselves at. Speak up for them. It's really carrying the cloak of someone else's life on your back and presenting that in a group to influence a decision or influence a policy. That's really what an advocate is, and it's probably the role that I appreciate the most as a nurse. Be persistent. If you know that you're bringing a new viewpoint or perspective, and the first couple of times that you say it, it feels like it just sort of just falls flat on the floor, remember, we're working in systems that have had their own way of just sort of keeping things going without any change for hundreds of years. And now you come along and you want change. Don't we all, right? To a certain extent. But that doesn't mean that change is going to happen tomorrow, but be persistent. Keep at it. It's really the consistent drop of water on the rock that breaks it down, as opposed to the one flood. Just be persistent. It's amazing how over time, people will begin to say, oh, I've never heard you say that before. And you're thinking, I've been talking about this for the last year. You just now, it's like, okay, fine. Great. So can you help me now? And move forward. It happens. Ask me. Be compelling. In order to convince others to help take on the change you'd like to see, you have to convince them. So many of you now as nursing students or as pre-nursing students, you will learn sort of the scientific way of thinking about things. You present a problem, you think about all of the stats that you need to really ensure that people have a sense of how big of a problem it is. You talk about what's been tried before, you come up with your idea about something different. With a little, if you can, a little support about why this different approach might be helpful. Sometimes it's just okay to say, you know what, we've been doing it this way for so long, our outcomes have not changed, maybe it's time we try something different. I've seen a best practice here, or I've read a journal article there, or whatever it is, but bring that forward and you can be very compelling in getting people to move things forward. Be mindful in how you approach people about change. Nobody really wants to change. You all have to do it in order to grow. And you know, there are a lot of famous quotes out there about what happens if you don't grow. But in reality, we are creatures of habit. And sometimes it just feels, you know, if you've got one more thing to do, you're just going to commit suicide, I swear. One more thing to do, you just can't do it. And so when somebody comes to you talking about change and you're thinking, are you kidding? This is the part of my life that I thought I had under control, and now you want me to change something. So that's the approach. That's the feedback that you'll get. You know, it's said a little bit more nicely, perhaps, but that's what people are thinking. So be mindful that as you continue to be persistent in advocating for the change that you think is important, that you just have to be persistent with people and be mindful in how today might not be the day that they're willing to hear it, but tomorrow it may be. And so just keep your approach even and just keep coming at it. Be passionately curious. That's really what research is about, right? You know something's going on with a couple of your patients. So when I decided to go back to earn my PhD, I really had all of these questions about differences between blacks and whites and what was going on in education and access to healthcare and yada, yada, yada. And my most favored mentor and advisor looked at me and said, you will never get out of here with any of those questions, so just stop it. This is not the place. And I looked at her and I thought, these are important questions. And she said, damn straight, they are. It's not the right time. I thought, okay. So I went away and I went back into practice. And I came back to her with a different question that was the same question. So I had just become a pulmonary CNS, and she really was my favorite advisor. Her name's Susan Jansen Berkeley, and I love her to death. I came back 5 years later, and I said, in my practice, I'm watching patients with asthma, and if they're white, they explain their symptoms as being much more chest-focused. But if they're black, they tend to explain their symptoms in the higher upper parts of their airway. They talk about throat tightness. And she looked at me and she said, really? Have you done any research? Have you seen anything in the literature about that? And I said, no. She goes, it's time for you to come back to graduate school. Now, it really was the same question. It really was the same type of thing she could say, you know what, you'll never get in here and get out of there with that kind of a question. It was still a black versus white question. And I really had seen that difference in my patients. So I came back to her with a patient-focused question. The timing had a lot to do with it. At the time, Susan was on the NIH asthma guideline panel to write the new guidelines for asthma management and care. And she looked at me and she said, I don't see any of this in the literature. You should do that work. So that is what I went back to my PhD work for. It was the right time for me. It was the right question at the right time. And there were two of us that were pulmonary CNSs working for the same practice. We went back together. One of us, sort of myself, went through this focus of then using that data to also get a better sense of how patients who are African American communicate their symptoms to providers. And my colleague went to the emergency room and started challenging people who were already having asthma attacks in the emergency room to see if it continued through the acute setting. So we both went back at the same time and we both did our research. And if you look at the guidelines, so I finished in 2004, Grace finished in 2003. If you look at the asthma guidelines in 2000 versus the ones in 2005, 2007, you'll notice there's a difference in the checklist of things that you look for and listen to in terms of asthma patients who come to the emergency room, because she was able to get some of that work in the guidelines. So sometimes all of that was really just being compelling and persistent and coming back to her with the same question I had initially, that she said, you'll never do it. But I was really passionate about it, and I was very curious about why that was happening. And that's really what feeds both you to question a lot of what's going on in your practice and will take you further in your work. Be engaged. So the students that I met with at lunch, I encouraged them to get involved with their professional societies. And I am a strong advocate of the American Nurses Association and their constituent state associations, because those are truly the watchdogs of your state practice and your licensure. Your specialty organizations are fabulous, and I belong to my specialty organizations as well. They support my practice. They support the best practices within my practice, within my specialty. They provide opportunities for you to, take leadership positions. They afford the opportunity for you to share what's going on with your patients with others of like-mindedness. So I am a strong advocate for nursing associations. It's also our ability to come together to enact change in terms of public policy and health policy. It's really hard to do as the singular individual nurse, but as a group, 3.3 million of us, we can do a lot in terms of pushing healthcare and patient-related policy forward, working through our organization. So I strongly encourage you to do that. And it will give you the opportunities both to have those conversations with those who can make a difference in the policy rooms, in the board rooms, as well as in your local communities. And then be a damn good nurse. And when I say that, I truly am going back to my very first B, and that is be an advocate for patients. There are lots of times when in my role in government relations in my state for the ANA affiliate there, I've had the opportunity to talk about what would be good for nursing, but I have found what is much more successful is to talk about what's good for patients. Because 9 times out of 10, if it's good for patients, it's good for nurses. 9 times out of 10. And I find that legislators will respond to what's going on with patients. Vote. We vote too, but it's not quite the same. It feels very different when you're advocating for yourself as opposed to when you're advocating for someone else. Nursing is about service. And there are times when in my generation, and certainly in my community, to think about service in that way, the hands go up, people start backing up from the table. It's like, I'm not doing that service thing. We have a history that's called slavery that some people equate to service. So it's really difficult to have it in that way. But service is really what nursing is about. And so if you think about your advocacy role in order to serve someone else, it's really what makes you the most formidable when it comes to the boardroom and the legislative room in order to make a difference. So that's it for me, and I'm happy to answer any questions that you might have.
Thank you very much.
Thank you.